Good evening, everyone. Welcome you all for the IPNA endorsed Webmaster Series 2021. It is an exclusive pediatric glomerular disease symposium, and we had a lot of polling competitions, and the winners will be announced on the coming Monday. And we have two eminent speakers today, and the session will be moderated by Dr. Edwin Fernando. Dr. Edwin Fernando is currently a professor and head of nephrology and renal transplantation at Government Stanley Medical College, Chennai. And he is also a senior consultant nephrologist at Mehta Group of Hospitals. And he helps us out in all the renal transplantation cases at Mehta Hospital. And his academic interest is towards renal transplantation. And he is also received Award of Excellence by Government of Tamil Nadu for the year 2018 and 2019. Now I request Dr. Edwin Fernando to introduce the speakers.
Thank you, Kalivani. Good evening to all. Good evening, Dr. Sidharth, Dr. Rupeesh, and all other participants in this webinar. We have two eminent speakers today, the first of whom will be Dr. Sidharth Sethi, who is a consultant pediatric nephrologist at the Medanta. In a short period of time, Dr. Sidharth has made great strides in the field of pediatric nephrology with a lot of accomplishments to his credit. He's been very instrumental in conducting a CRRT workshop for the benefit of pediatricians and pediatric nephrologists from all over the country. And he's the apt person to speak on acute kidney injury in children. Dr. Sidharth, the floor is yours.
Thank you, Dr. Fernando. And first of all, I would like to thank Dr. Kalaiwani and Mehta Children's Hospital for conducting this series of CME. It's a very important CME for everyone, for the academics to continue academics in this difficult time. And I would also like to thank IPNA for sponsoring this event. So the topic of my lecture is the newer advances in pediatric acute kidney injury. And over the next few minutes, what I'll do is I'll be taking you through what are the new updates, especially in the last 1 decade in the field of pediatric acute kidney injury. And we'll talk about from definitions to the management of pediatric AKI. So first of all, taking you through the new definitions of AKI for children. And it all started from 2007 when Dr. Ekan Eriken from Texas Children's, she modified the rifle criteria for pediatrics. And in that study, this was the first time when they modified it for children, they showed that the fluid overload and acute kidney injury, it occurs very early in the ICU. So remember that mortality, acute kidney injury, all of them occur very early in the ICU, especially in the first 7 days of ICU. And this study also showed that AKI was an independent predictor of mortality in these children. Now, all over the world, KDIGO classification for AKI is widely accepted. And as you can see on your left is the P-rifle criteria used in children and the KDIGO criteria, which are also now validated for children. If you look closely here, look at the RIF and stage 1, 2, 3 of KDIGO. They are comparable. And since KDIGO is also used for adults, so it's now a widely accepted definition for children as well. Now, how do we compare the Akin criteria to the P-rifle criteria to the KDIGO definitions? And this is the largest study done till date on comparing the definitions of the pediatric AKI in all of these children. Now, this was remember, this was one of the largest study looking at, it was a larger cohort of almost 14,000 children from Stanford. And when they found, and as you can see from the pie graphs here, that if you compare and apply on the same set of children, P-rifle tends to diagnose more early AKI as compared to the Akin and KDIGO. So whatever definition you use in your practice, whatever definition you use, remember that all definitions are good. All definitions, if you look at stage 1 versus stage 2 versus stage 3, all stages have very good inter-stage discrimination. They all correlate well with mortality. So if you look at stage 3, it does worse as compared to stage 2. and all of them correlate well with the length of stay in the pediatric ICU. If you look at P-rifle, it is a very sensitive criteria, and it looks at and helps you to diagnose more of early stage 1 cases. ECHIN is more selective, used in research setting. We don't use ECHIN more nowadays. However, if you want to look at the KDIGO criteria, so like I told, KDIGO is used in pediatric as well as in adults, and KDIGO is nowadays more used since as all of these children, they progress to adulthood. So we very commonly use the KDIGO criteria in children. Now, this was a study from the AKI advisory group from the American Society of Nephrology, and they looked at 24 studies looking at 14,000 children, and this study showed that AKI is common in children as well as in adults. So in fact, 1 in every 5 adults and 1 in every 3 children, they get AKI during the hospital stay. So it's not a very uncommon thing which we are talking about today. So if you compare demographically, what are the differences in AKI from different continents? On your left is Kenya, where the most common cause of AKI is infections, malaria. And on your right is the United States, where the common causes of AKI are after cardiac surgery, after bone marrow transplantation, genetic disorders in the developed world. Now, there are not many studies from India. And if you look at in our country, the most common causes have been acute tubular necrosis and hemolytic uremic syndrome. So if you look at what are the causes of AKI in our country over the last 4 decades. So this is data collated from few studies over the last 4 decades. And this blue is diarrhea. So diarrhea-associated acute tubular necrosis has drastically fallen because of the advancement in the pediatric care over the last many decades. This red is hemolytic uremic syndrome, which is still there and a very common cause of AKI in our country, followed by infections. So this green is infections and glomerulonephritis and few obstructive uropathies causing AKI in these children. Now, I'm happy to share with you, and I'm sure half of the audience is from South Asia, and all of them are aware about this, that since last 2 years, with the ISN and IPNA involvement in this, we are able to set up a South Asia pediatric AKI database. So it's a website where all the participants, you can see the flags here of all those countries. So all of our fellow pediatric nephrologists from South Asia, they enter data here of children who require dialysis due to AKI. So what we are trying to look at, we are trying to look at epidemiology of severe AKI in our part of the world. This is the website. If your center is not yet enrolled, I would request all of you to enroll your center. And I'm sure in the next coming months, we will be able to share more important data regarding the epidemiology of severe AKI in our part of the world. Now, coming to the conceptual model of AKI, and as all of us know as nephrologists, that children are referred to us late. So by the time a child is referred to us, he's already in kidney failure, fluid overloaded. However, we need to have a child, we need to identify this child who is at risk. So ideally, nephrologists, pediatric nephrologists should be involved in the care of these children earlier on. And we need to know who is at risk and who needs specialized renal care. So of course, ventilated children are at risk. So on your left is the data from Texas Children's. In your center is data from Montreal Children's. On your right is from LA. And all the studies show that AKI is common in sick children. It depends on how sick the patient is. So if you have a patient who is on your left ventilated on inotropes, he's at a higher risk of AKI as compared to on your right, you have children where you're looking at all the PICU admissions. So the incidence varies from 10% to 82%. Now, this is the largest ever multinational prospective study done from United States. It's called the AWARE study. Now, what this study did was that over 3 months, they used the KDIGO definition in children over multiple centers, and they found that the incidence of AKI was around 26% in children who were in ICUs, and the incidence of severe AKI was around 11%. Now, again, this study also showed the same interstage discrimination. And this is the Kaplan-Meier on your center, which shows that stage 3 does worse when you talk about survival as compared to stage 2, as compared to stage 1. So if a child gets AKI stage 3 in the ICU, his odds of death at day 28 is 1.77. So he has a higher odds of death at the time of, after a month of his ICU stay. It's common post cardiac surgery. And on your left and on your right, so on your left, you can see data from Montreal, where you can see that the incidence of AKI post cardiac surgery is 36%, while from Canada, this is especially looking at neonates undergoing a complex surgery. So if a small child undergoes a complex cardiac surgery, the risk of AKI is higher. Coming to our center from Medanta, in my center, we are very interested in cardiac surgery children, because cardiac surgery is a cohort which is not having any confounding factors. It's not like an adult undergoing a bypass. It's a naive child who underwent an elective surgery for his heart. So he was not having any septicemia, no diabetes, no other confounding factor. And now we are looking at an experimental model where we know when the insult occurred. So this is our initial data, where we looked at over 1 year, we looked at around 200 bypass children who underwent a cardiac surgery for a congenital heart disease. And we found that AKI was seen in around 10% of these children. And out of these 10% children, 4 got AKI stage 3. So 4 got AKI stage 3, and all of them required dialysis, and all of them died. So a severe AKI is, of course, a bad predictor of outcome in children, even after cardiac surgery. And we also found that younger the child, the increased cardiopulmonary bypass, complex is the surgery, higher is the chance of these children getting an AKI. Similarly, if this child requires a prolonged ventilator, he gets complications post-bypass, prolonged inotrope requirement after bypass, he's at a higher risk of going into AKI and mortality post-cardiac surgery. Now, it's not just about critically ill, it's also about non-critically ill children. So this is important data from Texas children, where they looked at children who received aminoglycosides for more than 5 days. So they found that every child who was just in the ward for receiving aminoglycosides for a prolonged period of time, and whatever definition you use, whether you use the pediatric rifle criteria or you use the Akin staging, the incidence of AKI was high, from 20% to 30%. And the risk factors were longer treatment with aminoglycosides, use of aminoglycosides in the previous month. So remember, we are not only talking about critically ill children today, even non-critically ill children who are receiving nephrotoxins in the ward are also at a higher risk. This is data from Dr. Goldstein's group, where they showed out of 1660 children, they found that if you increase the number of nephrotoxin exposure, so suppose if you give a child 2 nephrotoxins versus 3 nephrotoxins, there is a cumulative rise of AKI in these children, especially newborns. We all forget about giving, we are giving a newborn furosemide, we are giving him indomethacin, we are giving him colistin on the top of a child who is already birth asphyxiated. So these children are at a higher risk because they are exposed to multiple nephrotoxins in their NICU stay. And another study from Canada, where they showed that children who receive vancomycin for more than 2 days, who have a higher trough levels of vancomycin, they also have a almost 14 to 20% chance of going into acute kidney injury. Sometimes we just get stuck here. Let me try. Okay, so what about newborns? What about newborns? It's very common in newborns as well. And this is on your left. You can see whether you have a very low birth weight or you have an extremely low birth weight, a septicemic child, asphyxiated child, all sick newborns are at risk of AKI. And again, AKI is an independent predictor of mortality in sick newborns as well. Now, who gets AKI in newborns? This is a busy slide because there are multiple factors which cause AKI in newborns, from birth asphyxia to exposure of nephrotoxins, to maternal exposure of nephrotoxins, to requiring intubation at birth, and multiple factors causing AKI in newborns. Now, especially for the postgraduates and the fellows here, this is the most important study for neonatal AKI, the AWAKEN group. So what AWAKEN group did way back in 2017, and so they involved 4 countries, Australia, Canada, India, and our group was one of them with United States. And they just looked at 3-month retrospective data. It's just the 3-month retrospective data looking at newborns who require IV fluids for more than 24 hours. So newborns who require IV fluids for more than 24 hours. And this Lancet publication from the group showed
it may take some time.
Showed that smaller the baby, higher is the risk of AKI. So the risk of AKI was almost 27%, and it was higher in extremely preterm. So if you have an extreme preterm baby in your NICU who requires fluids, the risk of AKI is almost 50%. And thanks to an ISN clinical research grant, which we got way back in 2017, we were able to establish an Indian neonatal AKI consortium. So what we did is that initially we collaborated with multiple Cloud9 group of hospitals in the country, and now there are more than 11 centers involved. And what we do is using the same inclusion criteria of any newborn who requires IV fluids for more than 24 hours, prospectively, we are looking at what are the risk factors of AKI, what are the outcomes in these children. And I'm happy to share with you that now we have reached more than 2,200 newborns in the last 2 years. And we call this study a TINKER study. The protocol was just published in the Frontiers. So TINKER stands for the Indian Iconic Neonatal Kidney Educational Registry. And almost all centers, 11 centers from our country, are actively recruiting babies in this cohort. And we are looking and analyzing our data, and it's still on for the next many years to come. Now coming to, okay, we need to identify these children. And secondly, we also need to do some risk stratification. We need to know who is at risk so that a specialized renal care can be done. And the first risk stratification score was the RAI, the Renal Angina Index. So what it does is you just look at 2 parameters, the risk and the injury. So you multiply these 2, so you give a score to each. So for example, if you have a PICO admission or a stem cell transplant or a baby or a child on ventilator, so you give a score to the risk, multiply that with a sign of injury, which can be either reduction in the estimated creatinine clearance or increase in the fluid overload. So you multiply this. So the minimum score can be 1 multiplied by 1, and the maximum score can be 5 multiplied by 8, 40. And this initial study showed that renal angina index, it is able to predict severe AKI very well. And on your screen, you can see the area under the curve. And if you look at area under the curve of RAI, whether it's by reduction of estimated creatinine clearance or fluid overload, or worse of any of these 2, it does well than the classical PRISM 2 illness severity scores. So it does well and performs well, even better than the classical illness severity scores. And this study also showed that it also outperforms the KDIGO staging. So if you have a child who is angina positive, so most of the time they say RAI score more than 8. So if a patient has RAI score more than 8 in the triage, he has a very high likelihood to go into AKI in the next few days of the ICU stay. And from our TINKER database last month, we published the STARZ score. So the STARZ is after the developers. So what we did in our study over the last 2018 to 2019, we recruited around 1,400 newborn babies. So this is a risk stratification score for newborn babies. And we looked at almost 760 newborn babies. And based on that, we were able to find 10 scoring variables. So on your screen are 10 scoring simple variables. The age at the entry of NICU, whether he required a positive pressure ventilation, what is the gestation of the baby, septicemia, a heart disease. And on your right, is, you can see the sensitivity is very good, 92% with a good specificity and an accurate score to predict AKI in newborns. What we have done is we have even made an online dashboard for everyone. So all of you, if you just go to our website, thepcrrt.com, and on the website, you can find this dashboard. And even in sitting in your NICU with your cell phone, you can just enter the variables and you can find the score. And higher the score, higher is the chance of this baby getting an AKI. And over the next few weeks, what we are doing is we are trying to validate this score in another 700 babies recruited from 2019 to 2020. And we'll be sharing the results with you very soon in our future publications. Now, what about risk stratification in pediatric cardiac surgery? And I'm very happy to share with you the thesis of one of our DNB students, Dr. Arushi. And her thesis was basically on looking at cardiac surgery in children and trying to look what can predict AKI in cardiac surgery. And I'm happy to share with you that yesterday we got an email from pediatric nephrology. It's been accepted in pediatric nephrology. So what she did was that she was able to make a clinical predictive model. So based on age, gender, the complexity of the cardiac surgery this child is going into, whether he is going into a very severe, so RAC score is a severe, it's basically a cardiac surgery complexity score. The serum creatinine at admission, GFR, type of heart surgery, cardiopulmonary bypass time. So once you get a child who got a cardiopulmonary bypass, you apply a cardiac predictive model. On the top of that, you also look at the preoperative proteinuria. So you also look at preoperative proteinuria. So on your screen, I know I can't mark it here, but if you look at first, second, third, the fifth from above, the clinical model plus preoperative albuminuria, the area under the curve is excellent. So what I'm trying to say is, if you have a baby who undergoes a bypass and you also have a preoperative proteinuria, if it's high, you can predict AKI just on the basis of this. Okay, so there was another study from Dr. Zapitelli which talked about post-operative ACR. However, we found that post-operative albumin creatinine ratio was not very good predictor of AKI. So we still found that it's basically a combination of clinical model and a pre-operative ACR. So just to have an idea, if you have a child undergoing a cardiac surgery, think about these models to predict AKI. What about biomarkers and fluid overload? I won't go into the details of biomarkers because it's another big talk. But what I would like to share with you is that, again, in a triage, if you have a patient where you calculate the RAI, okay, and on the top of that, you do NGAL. And on your right is the area under the curve, 0.97. So as an emerging country, so we don't want to, use NGAL in all of these babies, all of these children who come to the triage. But if you have a selected patient who is looking sick, who has a high risk stratification score, and you apply biomarkers only to these selected group of patients, you will have a good yield of your biomarker. So you don't need to spend money on each and every patient, and you get a good predictability. And then you can do your renal interventions to prevent the complications in these patients. Now, talking about fluid overload, and this is photograph of Paracelsus. Paracelsus is known as the father of toxicology. He once said that it's, everything is a toxin, everything is a poison. So it's the dose which determines it is poison or not. So everything can be a poisonous state if you use a higher dose. Talking about fluid overload, and this is the data of our pediatric ICU in sick children. So these are not children on dialysis, sick children. And we found that children who are sick, they go into fluid overload early in the ICU. Children get AKI early in the ICU. Children die early within the 5 days of ICU. And the fluid overload correlates well with their oxygenation requirement. So on your screen is the correlation index of fluid overload with the oxygenation index, and it correlates well. And on your screen, you can see here, higher is the fluid overload, better is the strength of association of fluid overload with the oxygenation index in these children. So higher is the fluid overload. So on your screen, you can see if you have a patient who is more than 15% overloaded, he is also impaired in his oxygenation. And mind you, these are not children on dialysis. They were excluded in this study. So all of you, especially for the residents here, please look at the fluid overload in all patients. So this is the definition, the total fluid in minus out divided by the admission weight multiplied by 100. Now, you need to do the fluid overload every day, cumulative, every day look at this, because this is an excellent data from the prospective PCRRT registry, where they showed that higher is the fluid overload at the initiation of CRRT, higher is the mortality in these patients. So we need to intervene early, okay? Not when these children are already fluid overloaded. So somewhere around more than 15% of fluid overload, we need to think about intervening. So this is the dream algorithm for all of us. When a patient is admitted in the ICU and he's just about to be admitted in the ICU, do a RAI or a risk stratification score. And only to children on your above panel, children who are RAI positive, who have a high risk stratification score. In these patients, you do a biomarker assessment and start your renal intervention, which may be talking about avoiding overload, limiting nephrotoxins, avoiding contrast, okay, or maybe even considering RRT early in these patients. So we talked about biomarkers, preventing fluid overload and nephrotoxins. Now, I'll not talk about nutrition. Nutrition is a very important aspect, and a very important review article has been published by a group in pediatric nephrology a few years back, talking about RRT. And we are very excited about new devices coming for children. On your left is Aquadex, a good device for smaller children where you can remove more fluids. On your right is the new infant Newcastle device from Newcastle, from UK. And the trials are underway to look at whether this can be a good device, especially for children. So a different device for a pediatric patient. So this is again a photograph of Nidus. But all of us are especially excited about Carpe Diem. This is the cardio-renal pediatric emergency machine made by Dr. Ronco's group from Italy. And this machine has been approved by the FDA. I know Dr. Rupeesh is here. Most of the United States centers are now undergoing training to use this device in the United States. And maybe in the next few years, it will come in our country as well. So we are excited about this. However, in our country, since we don't have, in our part of the world, we don't have CRRT in all the centers. We don't have Carpe Diem yet. So over the last many years, we've been looking at SLEDD, a sustained low efficiency dialysis for sick children. So we started off with a retrospective analysis from 3 centers, from Delhi, West Bengal, and Pune. And we showed that it was feasible in sick children. And then we started using SLEDD with F, using SLEDD with convection, using the 5008 series of Fresenius. And we could show that in children who are around 8 kg or more, we could do SLEDD heparin free. So we don't need to give heparin or even citrate, which was used in CRRT. And you can see on your screen, the premature session terminations, hypotension was less than 10%. So it was managed, and these children could tolerate the SLEDD with convection well in our country. And way back, 2 years back in Melbourne, in WCN, we had a workshop where we discussed the guidelines, and these guidelines have been published. And all of you can access this paper, which talks about the current guidelines of using intermittent SLEDD in these children who are critically ill in the ICU. So talking about follow-up, we talked about management of AKI. Do we need to follow up these children as well? And there are multiple studies on your screen. And the 4th study from above, Dr. Cherry Memon from Canada, was the only prospective study till now looking at the outcome of children who get AKI. And Dr. Cherry Memon's study showed that children who get an AKI, this is data from Cherry Memon's group from British Columbia, where they showed that children who get AKI, they have a higher risk of going into CKD, hypertension, proteinuria, and even hyperfiltration. So this group also showed that some of these kids also had a higher GFR. So maybe they were hyperfiltering in this group. So there are multiple studies. I'm showing a busy slide. However, it all means that children who have AKI are at risk of hypertension, proteinuria, going into CKD, and worse outcomes in these babies. Now, what happens? How long do we need to follow these children who get an AKI? Now, this is a question still in our mind. And this was a paper from Dr. Prasad Devarajan's group, where they showed that even when creatinine has normalized, there's no hypertension, there's no proteinuria, but even 7 years after a bypass, children still have abnormal biomarkers. So if you have a patient who got a cardiac surgery, AKI, they still have abnormal biomarkers even 7 years post cardiac surgery. So especially the KIM1 to creatinine ratio, the NGAL to creatinine ratio, and the LFABP to creatinine ratio. Thanks to an ISN grant way back, almost 6 years back, we started looking at long-term outcomes of children who undergo cardiac surgery associated AKI. So we looked at 2,000 babies who underwent a bypass in our hospital in the last 10 years. We called all of them, whether they got an AKI or no AKI, and we did a biomarker evaluation in these babies. And I'll just show you the results. So the results showed that these children also had higher biomarker excretion. Again, the same story, that there is still abnormal urinary KIM1 to creatinine ratio, abnormal LFABP to creatinine ratio. So maybe these children, there is still some ongoing inflammation going on in these children, and we need to follow up these children to look for what happens to these children later in their lives. So there are a lot of things which have happened in the last decade, and I would just like to point you towards the right lower panel. A lot of PCRRT guidelines have been published in the last many years. Dr. Raina is the next speaker, and I would like to thank Dr. Rupeesh Raina for leading many guidelines. And we are all, as a PCRRT group, about to publish 2 and 3 important new guidelines also in the next 1 year. So all of you, please stay tuned for new guidelines for AKI and do read them. And before stopping, I would also like to mention, because this talk cannot finish without talking about pediatric COVID-19. So we recently did an analysis of children who are in the ICU, children with COVID in the ICU, and what happens, and we compare that with adults. So on your screen, almost 1,200 children who were in the ICU were recruited, and the median age was around 9 years. And now this green is children and the blue is adults. So this was a meta-analysis of looking at AKI in children versus adults. The AKI incidence was, however, higher in admitted COVID pediatric children. However, as we are all aware that the mortality was just 1.9%, so mortality is less in children. The use of KRT is less in children. However, it's important that we need to monitor children who are admitted with COVID-19 in your hospital, especially for MISC, the multi-inflammatory syndrome in children. And there are important guidelines by the PCRRT group here, which were recently published. And I think we should all follow. It's not about which modality you have. It's not about whether you have a SMART CRRT or you have a SLEDD with a F or you have PD. It's about initiating this dialysis early and in the proper manner. And like Dr. Bunchman always says, you need to do what you are good at. So it's not about being smart. It's about, if you have PD, you can save life. I got multiple queries in this COVID era about whether we can do PD in a child with COVID. Of course, we can do PD in a child with COVID. So it needs to be early and when required. So this algorithm just states that. And I would also take an liberty to invite all of you to our meeting, which we do annually since last 10 years. And next month on the same date, we have a pediatric critical care nephrology course, which will be also talking about point of care ultrasound, another new advancement in pediatric critical care, and the new devices, along with a panel discussion on COVID-19. The website is on your screen, and I would again like to thank the organizers for inviting me here. Thank you.
Thank you, Dr. Sethi, for the excellent review of the subject. Since we are running short of time, we'll take your questions at the end of Dr. Raina's session. Now I invite Dr. Rupeesh Raina to introduce Dr. Rupeesh Raina. He's a adult pediatric kidney disease hypertension nephrologist at the Akron General Medical Center at the Cleveland Clinical Foundation. He's associate professor at the Neonatal Medical University and Case Western Reserve University, Cleveland. He's a pediatric education committee member for the International Society of Nephrology and fellow of the National Kidney Foundation and American Society of Nephrology. He has specific academic interests in adolescent and chronic renal disease, transition from childhood to adulthood, RRT in AKI, bone marrow transplant, inherited metabolic diseases. And he would be speaking on FSGS and how the resorptive therapies are going to help in FSGS. Dr. Raina, the floor is yours. Have we lost Dr. Raina?
No, he's right. I see the calls. That's fine. Hello? Hello? Hello?
Yes, we can hear you, Dr. Raina. We can hear you.
Okay. Do you want me to start or sorry, I was...
Yes, please start, Dr. Raina. Start.
Okay. Well, good morning and good evening to all of you. My topic today was the low density lipoprotein apheresis for preventing reoccurrence of FSGS in kidney transplantation. I'm an adult and pediatric nephrologist, and I work in Akron General for adult and pediatrics. Actually, I work in Akron Children's. Going back to our course objective, after taking this course, participant will be able to describe the effect of hyperlipidemia on chronic progressive glomerular disease and tuberous interstitial injury. I will list the current technique of LDL apheresis and identify the most efficacious treatment for removal of LDL and lipoprotein, and explain the mechanism of action and risk associated with LDL apheresis. So going back to the FSGS now, we have changed the spectrum. It's actually a histological finding. I call FSGS more or less a spectrum or a syndrome that is associated and that entails primary and secondary. It typically presents with proteinuria and has a high risk of progressive loss of renal function. And this is one of the disease as a pediatric or as an adult nephrologist, it's a challenge because only 25 to 30% of the patients, they respond well. Most of them, they linger on with persistence or progressive FSGS. And in long-term cohort studies in adult and children with primary FSGS, renal survivor has been associated with proteinuria, which is not true only for FSGS. That's actually true for any kind of disorder for renal diseases. Now, what are the things we have now? We have some current strategies for control of FSGS use, a stepwise approach with goal normalization of urine protein excretion and prevention of the kidney failure, prevention of the glomerular sclerosis or ESRD. Now, progress in the field remains a priority in order to prevent the trajectory towards renal failure for patients proven to be resistant to the treatment, to identify any therapeutic regimes with minimal toxicity. And it's been a challenge, ongoing challenge for a long time. The biggest concern we get is basically when you look at is the recurrence of FSGS after the kidney transplantation, because FSGS can reoccur after kidney transplantation. It was suggested that humoral factors influencing the glomerular permeability may be involved in its reoccurrence, and there was some concern about super reproducibility, but definitely there are some of the humoral factors that actually cause the leaky membrane and primes them for the FSGS. And the recurrence rate after the transplantation is around 20 to 50%. Now, there are two kinds of reoccurrence in FSGS. Number one is the primary that occurs between 2 to 4 weeks, some of the time within 2 weeks. And then secondary, it can occur later on around 1 to 2 years. And that has a lot of confounding factors, including immunosuppressions, rejections, also kind of sometime overlap with the transplant glomerulopathy. So that needs to be clear. What are the standard of treatment we have for the reoccurrence of FSGS after the kidney transplantation? It varies from institute to institute. Most of the time it's universal. We use steroid pulse therapy, plasma exchange, and administration of rituximab, which is an anti-CD20 monoclonal antibodies, which has been tried with minimal responses. Now, FSGS after the transplant, as I said, it's early recognized by massive proteinuria, even hours to days after the transplantation. And as I said, late occurs after months and years. Now, what was the reason behind? It's actually a fascinating story. When the lipoabsorber was coming into action, I was not pretty convinced in the beginning about the possibility. And whenever you take any new devices, at least in the US, it has a lot of clearance. You need to get an exemption. You need to have an IRB. What this device came to me for the first time, and one of my partner in crime, JJ, that's Jerisky, told me that there will be a possibility of decreasing or absorbing the potent pathogenic permeability factor that might be expected. And the way we can do it is an adsorption technique by using LDL apheresis. Imagine this about 3 years ago, how much limited we were with using the adsorption technique, because now in the era of the COVID-19, we have a pretty intense involvement of the adsorption technique, and now the paradigm in the AKI has changed. Now, at least super rapid reoccurrence of FSGS, such as 1 to 14 days after the transplantation, could be prevented with the LDL apheresis. And this is nothing new. Actually, for US, we were pretty new to have this, but this is an ongoing thing going on in Japan, and there's a lot of data behind it before it was taken into account or was approved by FDA for children less than 18 years. Now, it has been also approved for adult, and it's under the process. Maybe that is a therapy we will be using for the resistance FSGS, and definitely there is an area for the post-transplant FSGS reoccurrence. Then when we were going through that, then I want to know, like, what is an LDL apheresis mechanism is, and how does the LDL can cause the FSGS, and what was going on. But if you go back, there's a huge literature that direct effect of lipid adsorption. It causes a reduction of the macrophage stimulation by oxidized LDL. It actually ameliorates the macrophage dysfunction, reduce the inflammatory cytokine, which makes more sense in the setting of the post-transplant. It does causes vasodilator and anticoagulation effect by absorption of various pathogenic factors by dextran sulfate, and I'll come to you with a different kind of modality we have for this LDL apheresis. It does cause reduction of fibrogen and coagulation factor. It increases VGF, nitric oxide, bradykinin. It's all been shown. We have looked at too. And it's also causes the adsorption of vascular permeability factor, which I personally feel is a very important mechanism for at least for the chemotherapy. Now, enhancement of immunosuppressive response by improved intracellular drug transport. It helps in improved corticosteroid response. It enhances the transmembrane cyclosporin transport via lipoprotein receptor. This is amazing. Sorry, my slides are moving fast. So this is the most important part, which I really, really will appreciate the things that we have seen in LDL. What it does is in LDL apheresis, it somehow initiate or potentiate the corticosteroid response. And it also potentiate the response with the immunosuppression, especially the calcineurin. The studies are mainly done in cyclosporin by the transport of the lipoprotein receptor, and it inhibits the effect on MDR1 gene expression. So this was kind of multifaceted response with LDL apheresis. This is a paper which got published where we talked about the role of lipopheresis in cardiovascular disease reduction. This FSGS is one of the spectrum, but there are other diseases that could be affected and could be prevented by lipopheresis. What was the link between lipids and CKD? And this is something you have to understand. There are 4 mechanisms how the hyperlipidemia or hypercholesteremia can cause the FSGS. Number 1 is the lipiduria itself, which causes the tuberous interstitial injury and cause interstitial fibrosis, lead to progression of the renal disease. Then you have a vascular endothelial injury that potentiate the endothelial damage, atherosclerosis, and hypertension. But these are the 2 mechanisms which was pretty was very interesting to see that it also causes the mesangial cell proliferation by decreasing the adenopectin, increasing IL-6 TNF-alpha, and increasing the MCP1. And there is some history, or there's some studies which shows it causes a deposition in glomerulus, and that's what we used to call like lipoid nephrosis for minimal change disease. This all initiated the macrophage infiltration and increase in the mesangial matrix. The culprit here are increasing TGF-beta, PA1, IL-6, TNF-alpha, and this all initiate the production of the renal reactive oxygen species, and that could all lead to glomerular sclerosis and progressive renal disease. At that time, I was agreed that there is an evidence not only on the bench, but also on the bedside and transitional model that lipiduria or lipid itself would be a potentiation or can potentiate the CKD. This is our paper that got published in LDL apheresis with nephrotic syndrome. A beautiful paper that I will request all of you to read about. What is the role of LDL apheresis? And some of the things can help in apheresis is the recovery of the macrophage function, prevention of the proximal tubular injury and tubular interstitial disease, any enhancement response to the immune response and steroid, which we have seen in post-transplant. Actually, we do the apheresis. I have a patient with which I followed when I was a resident, and he was on lipopheresis before the transplant. His genetic test was all negative. He just reoccurred, FSGS reoccurred in 2 to 4 weeks, and we have actually did a lipopheresis on him after the transplant. You'll be surprised that the steroid response that I gave him, he was 17-year-old, was very potentiated, and the same person is now, the graft is saved, but he responded well with cyclosporin, which was not the case prior the transplant. He was resistant to all of the treatment. To an extent, we gave him rituximab. We did everything what we can, but definitely there is a lot of data on enhancement of response to the immunosuppressants and steroid. It does prevent the vascular endothelial injury, and there are some anti-inflammatory effect. This is how it's a pretty crowded slide, but I just want to show and reiterate what we have. This is mainly talking about how does it affect the FSGS, mesangial proliferation, lipiduria, interstitial injury, and activation of the macrophage. Then this was going on, and I did the training, and I was listening to the company from Japan about the adsorption mechanic. This is very fascinating. It's very size selective, and it's actually an electrostatic interaction with HDL and LDL. And this is what it does. It's actually lipoabsorber as a direct hemoperfusion. It reduces the LDL-C around 68 to 80%, 70 to 78% of lipoprotein, and triglyceride 54 to 56, and HDL-C from 12 to 17. When I did this first treatment, it was amazing. These lipoabsorber direct hemoperfusions are all like white. And as soon as the blood go through, they look like mac and cheese. It was so selective absorption, and it's in such a short treatment with mainly its effect is in LDL and lipoprotein lipase and triglycerides. Then we looked around when this technique came in, and I said, why there are many other immunoabsorption therapy? Can we use dextran sulfase? Can we use heparin? Can we use direct adsorption lipoprotein, DALI? The mechanism that Kaneka has been using is a dextran sulfate cellulose adsorption. And my question was, why we picked up this? So we did a review, and we found out the response of the decrease of the LDL with the dextran sulfase was around 76 to 81%, lipoprotein lipase by 65 to 68%. And this is an important slide because you have some questions at the end. This is the only mechanism where you have a pretty intense response or absorption with the LDL. I know there is a controversy. People talk about super and chemokine factors, but one thing is, if you can remove LDL through this or this adsorption mechanism, you can remove any chemokine factors which is present, because LDL is pretty big protein to be removed. So that's the reason why we use Kaneka, because it has dextran sulfase cellular adsorption technique. This is another new concept that came out, and this is something is very, very fascinating when this was going on. And I said, why albumin-associated free fatty acid induces the macropinocytosis in podocyte? This is a beautiful article in Journal of Clinical Investigation. What they were saying is that podocytes are capable of internalizing large amount of extracellular fluid and molecule by the macropinocytosis. Very, very nice mechanism. And it is non-specific process that results in small vesicles around 0.1 micrometer in diameter and involve both coated and non-coated vesicles, an active clearance mechanism to prevent the filter from clogging. So podocyte itself is a specialized role in update and removal of these plasma protein that crosses the GBM. Significant urinary loss of albumin decreases the plasma lipid buffering capacity, and you have elevated level of unbound free fatty acids. One of our favorite board questions. And that's a litmus test. If you are confused between glomerular nephritis and nephrotic syndrome, just throw in the lipid panel, not like even fasting, you'll see high triglyceride level. And that's something it's more odd of having nephrotic versus nephritic. So what happened is, when you have this elevated unbound FFP, they increase the circulating NPTL4. And this inhibits the lipoprotein lipase and thereby lead to elevated plasma triglyceride levels. Actually, the studies have shown that AGNPTL4 expresses in podocyte, which induces proteinuria. The mechanism is not very clear. This new concept was put in when this device was in place, is maybe excessive macropinocytosis and accumulation of albumin in podocyte may lead to the lysosomal dysfunction and podocyte loss, which was very well proven before, what we call as maladaptive response. I was convinced with the LDL apheresis at this point of time. I was pretty convinced that I have to use the dextran sulfate absorption because of the capacity of absorbing the LDL, podocyte injury leading to albuminuria and hyperlipidemia. And then these lead to an increase in the FFA and albumin ratio, causing vicious cycle of persistent podocyte damage, and albuminuria converts proteinuria into nephrotic syndrome. So at that time, I was pretty convinced, therefore, lipoprotein apheresis to lower lipid level could be, in theory, reduce proteinuria and improve renal function. We were all set. Then we looked into the FDA. What are the other indications that can be used, or which is the other FDA indications for lipoprotein or the lipopheresis? These are family hypercholesteremia, peripheral arterial occlusive disease, FSGS, refractive. Now you have to be very, very careful The definition of FSGS, which FDA approved, is you need to have standard medical resistance with eGFR more than 60, post-renal transplant, primary recurrence of FSGS. And then also, if you have FSGS with standard medical resistance and your LDL is more than 250, that's also an indication for lipopheresis. This is a system how the lipopheresis works. As I told you, that is like two adsorption mechanism that it goes in parallel to each other. And this is how does it work. Then we looked into the therapy. It's done 2 times a week for 3 weeks, then once a week for 6 weeks. And plasma volume is treated is determined by multiple patients' weight, multiplying the patient's weight in kilogram by 60 and result in rounded up to near 100. You need to use an heparin anticoagulation. Priming solution is around 2,000 to 3,000 USP unit of heparin in 1:1 of ringalactate. Loading dose is 25 units per kilogram. Reduced dose if abnormal PTT and APTT. Continuous infusion needed is around 25 units per kilogram per hour. And we do the bedside ACT. It should be maintained around 1.5 to 3 times the normal range. Normally is around 1,000 to 3,000 units of heparin per hour is adequate, and is pumped using heparin infusion pump into the blood withdrawal line. So we didn't have a lot of anticoagulation. Good thing is they didn't clot it much. The bedside ACT really helped. So we were moving along with this process. Then we came out, okay, what are we doing, like using LDL apheresis to treat nephrotic syndrome? Does it make sense? Now we have the machine, we have the protocol up. In sense of nephrotic syndrome, it represents a common endpoint is a podocyte injury, which you have seen, especially in FSGS. It does not matter. There could be 1,000 mechanisms of podocyte injury. One example is that patient would otherwise need nephrectomy, dialysis, and then transplant with the risk of reoccurrence. Could LDL apheresis allow this patient to keep their kidneys? And another was the congenital nephrotic. We do everything, and ultimately I have one congenital nephrotic in-house now on PD with nephrectomy. Then we thought this is nothing new. There is a lot of studies. The studies has been going on as long as like in 1994, 1996, you have in 2000, some of them were prospective studies, some of them were retrospective studies. And most of the time the efficacy actually ranged between 57 to 86%. And this was very convincing. And most of the indication that they have used this therapy was in minimal change with the nephrotic syndrome with steroid resistance, IgA, and they have also used in the setting of membranous nephropathy, which is not an indication for here in FDA, is only approved for FSGS. This is a very nice paper by Hattori et al., and this shows how the proteinuria kind of got improved with the length of follow-up even after the treatment. And this is another one with GFR being maintained after the lipoabsorber. Then my question was, I understand there is a data, there's already a case series, and I will say a cohort which has responded, response rate ranging between 50 to 56. What will be the prediction of the response? How can I predict that this mechanism is working? What we do in this kind of setting is, this is a new concept I learned during the process, is known as the selectivity index, which was calculated according to the Cameron and Blatford method using following formula. And we found out that the selective response by this calculation will tell you that you are preventing the chemokine programming or maybe a podocyte injury. The only complication was a line infection. When I looked into the limitation, there were only small numbers. Then we thought maybe it is just a spontaneous remission, but that may not be true if you do the literature search, which we did. We have published that paper in Blood Purification. It was not by chance. These patients were thrown into a kitchen sink. Everything was given to them before they went to the lipoabsorber. And same in my studies, when we did it in the US with JJ and other centers, these patients were resistant to everything to an extent. We gave them rituximab and they were resistant, not responding. So this is another study which was done by Musso et al., published in Nephron, which it shows us that with the LDL apheresis group, there's a marked improvement in proteinuria. There's marked improvement in albuminuria, which also open up the new concept of selective proteinuria, which has been shown and upcoming very well, where the selective proteinuria predicts the response or should predict the mortality and morbidity of FSGS. Then we looked into the major clinical studies of lipoabsorber. There's a study by Musso, by Stenwinkel, and then Yokoyama, 1998, and then there's mainly by Sakai in 1994. And these are the number of treatment, which most of them, they do like 3 weeks, 2 times, and then 3 weeks, 6 weeks every week, has been pretty consistent. And you can see that the clinical efficacy was ranging between 57 to almost going to 86%. And again, you have to take the data because these are very few patients. And I like the Yokoyama data because these patients have a lot of medications already given prior. And what they found out, the summary was there was a reduction in the remission induction period. There's an increased serum albumin. There's increased serum albumin effective in the younger age. Also, in Musso study, they found the amelioration of apoprotein B deposition in glomerulus 5 in 6 cases. I like the Sakai data, which shows 50% reduction in proteinuria in 9 cases. And Hattori, which I have explained you, the patients were all FSGS with cyclosporin resistance. Remission was 5, partial remission was 2. It was effective in 76% of these patients. So we were now pretty confident. What was the thought process? How does this mechanism work? New concept of selective proteinuria, new concept of looking into the response. And then we moved on looking not only the lipoabsorber with the other mechanism, we did the clinical review to find out, okay, this has been there since 1994. People are using dextran sulfase immunoabsorption. This is the paper that came out, which is a combined LDL apheresis and prednisone therapy for steroid-resistant primary FSGS. And they did twice for a week, 3 weeks, and then weekly for 6 weeks. There were 11 pediatric patients which are cyclosporin resistant. 7 patients have a remission as 5 patients complete within 4 weeks and 2 weeks with 2 patients with partial. And this was the data that was reviewed by the FDA, and they looked on the other study. By the time I came into the picture, the Polaris was already out, which was a prospective observation survey on a long-term effect of LDL apheresis on drug-resistant nephrotic syndrome, and short-term clinical effectiveness was looked into 1 month. Long-term outcome was around 2 years, and there was a multicentric prospective study with 47 patients enrolled. And you can see that the efficacy just after lipoabsorber treatment, you can say around from 3.5, it range between 1 to 3.5, which I will call a partial remission, which was around 15 out of 47. Complete remission was 10 out of 47, which is 21%, and it was not very effective in 15 out of 47. So again, these patients were not naive patients. They got treated with multiple immunosuppression prior to the treatment. Then remission rate at 2 years, we found out complete remission was persistent in 25%, incomplete around 22%, incomplete remission 25%, no effect in 27%. Nearly half of the patient, they achieved favorable outcome of urine protein less than 1 gram per day. More than 70% of patients could evacuate. I will tell the term in most of these patients, around 70% of them, they have proteinuria less than 3.5. This is a fascinating article, and I really want to, and I spent a lot of time to kind of make this diagram to make it more perspective, the mechanism of glucocorticoid action and factor, which is engaged in development of steroid resistance. So what happened is LDL apheresis, it represses the MDR1 gene, which increases the elimination of the glucocorticoid. LDL apheresis upregulate the GC receptor, and it modified the nuclear import, and that causes these patients by restoration of cellular uptake and inhibition of drug efflux that helps more cyclosporin and steroid responsiveness. And we have seen that in post-transplant. You can see the improvement in the bioavailability of the cyclosporin by normalizing the elevated serum levels. So we were pretty sure that there's a long-term treatment of adult and peds, rapid long-term therapeutic effect. It improves nephrotic syndrome with delipidation, and recommendations, several guidelines in Japan. So we got this approval from the Humanitarian Divide Exemption by USA, authorized by the federal law for use in the treatment of pediatric patients with nephrotic syndrome. The criteria was standard treatment options, including corticosteroid and calcineurin inhibitor, are unsuccessful or not well tolerated, and the patient glomerular filtration rate is more than 60. The patient, if it's post-renal transplantation, then these criteria doesn't work. These are mainly for FSGS. And I always tell the patient, this is not like a naive patient comes in with FSGS and you put them into lipo. You need to prove that they are progressive, they are not responding, they have all these things need to be very clear when you go for FDA. FDA warns you and tell you this is the indication is. Sometimes they come back to me and they said, oh my God, this is not approved. I said, no, because the indication of the GFR needs to be more than 60 and they should be resistant to the treatment. They should be unsuccessful for the various kind of immunosuppressions that they have given. And that doesn't mean that you have a partial remission. You need to be total in relapse, including physical signs of edema and progressions. Now, inclusion criteria was refractive nephrotic syndrome in which standard treatment options are unsuccessful, or it was not very well tolerated, or in which standard therapy is contraindicated. Pediatric post-transplant patient with nephrotic syndrome associated with primary FSGS. That means they should be negative for any kind of other genetic factors. This is our first multicentric trial that was published actually where we have this dextrose sulfate plasma adsorption lipoprotein mechanism, and multiple centers were involved. And of October 2017, we have 14 patients from 6 sites has been enrolled. A total of 11 completed 12 apheresis treatment over 9 weeks. At that interim, 25% in 1 month attained partial remission, and furthermore, 33 and 100% had partial complete remission at 3 and 6 months. Only 1 patient who was followed up to 12 months had complete remission of the nephrotic syndrome. And there was improvement of stable eGFR was noted in all the patients, 100% over the follow-up period. Now we are following these patients down the road with more down effect to see if there was some response. This is the patient's population that we have. Then there was a whole data with the preoperative low-density lipoprotein apheresis for preventing recurrence of FSGS after kidney transplantation. And it has been shown people are using it. Then the paper came out there was another paper which was published, the post-preoperative LDL apheresis for preventing of the glomerular FSGS when the patients have a high risk. And actually, Sidharth and I'm working with our recurrent FSGS guideline, which believe me is going on for a year. I'm really pulling out my hairs and binding on my teeth. It's taking us a lot of time. Such a controversial topic it is. With less data, we are working on that part. Now, this is a proteinuria. You can see this responded so well with the treatment, and that something needs to be kind of more responsive to that pattern. Now, this is the data that Zereski and people have published as 7 patients, and there was a dramatic response. And I have one, I told you my experience. These are the effect of proteinuria and other things. So these are some of the most recent eGFR after the LDL apheresis completion and time of most recent follow-up since last LDA completion. I'll conclude this talk because, still the data needs to be done. Is basically LDL apheresis is a novel therapy for drug-resistant primary FSGS and post-renal transplant FSGS recurrence. However, long-term evaluation of the outcome in the larger studies required to confirm these findings. This is not an easy study to do. These are drug device related in the US at least. And we found that 3 and 6 months, the response was 33 and 100%, and all the patients showed stable or improved eGFR. Giving these interim results, full analysis after completion of the study will shed some more light on the outcome of LDL apheresis using the lipopheresis. With this, I'll end with some questions. Which of the following is the mechanism through which podocytes are injured by free fatty acid? I have 4 options, A, B, C, D. The answer is unbound FFA caused disruption of the micropinocytes regulation. And this is something I really want you all to read about, the novel concept in FSGS. What is the most widely used technique in the management of drug-resistant nephrotic syndrome and familial hypercholesteremia? It's actually heparin, dextrose sulfate cellular adsorption, because you want to help to remove the LDL and the lipoprotein. Which of the following is a direct effect of lipid absorption? A reduction of the macrophage stimulation by oxidized LDL and amyloidation of the macrophage. With this, I'll end my talk. These are our collaborators, our centers who are enrolling the patient. My special thanks to my research fellow, Dr. Sidharth Singh, for helping me in the study and also kind of making some of these multiple choice questions that are hard to kind of blend in. and my partner in crime, Joshua Jaritsky. So we'll see when more data will come, we can have more information for you guys. With that, I want to end my talk. Thanks.
Thank you, Dr. Raina. That was excellent work, mind-boggling, in fact. We wish that we were able to implement all this in this part of the world where we see a large number of patients with FSGS. So coming to the question answer session, there's one question that I would like to ask Dr. Sethi regarding the biomarkers in AKI. I think both of you could answer also. Do you think a next classification or staging of AKI should include the biomarkers in the staging itself?
Yeah, ideally, yes. However, as you're aware, in our part of the world, we are not able to use that. And if you look at Dr. Devarajan's studies, if you especially look at the follow-up studies, there are a lot of patients whom they are looking at who were creatinine normal, they had no proteinuria, and just NGAL positive. Because there are, especially in the adult world, there are some studies that if you have a patient who just had NGAL positivity, creatinine was normal, still these patients may have worse outcomes. So I agree with you that you may need to look at these patients who are just NGAL positive and creatinine was just normal in these patients. And what do you think, Dr. Raina?
Biomarkers, still like, I wish we have something for you to tell about angina doing the troponin. These are still, I think, a place where I feel biomarker has some role is especially after the cardiac surgeries. That has been proven with a very good sensitivity and specificity. The thing is, by the time, we had Sidharth and I had a very nice paper published in Pediatric Research about the update. When we get consulted, there's only renal failure and death. There's no primordial consult. And by the time we reach there, the things are already damaged. It's more worse in adults. So when you're talking about the biomarkers and all, this can only happen in the setting when you are looking for perioperative, like cardiac surgery, or you're looking for any major procedures. But if you talk about these in the setting of AKI ATN, when we get consulted, there are a lot of confounders. Patient got fluid, patient got antibiotic. At that time, the biomarkers are not very valuable. So you can only do that in an elective procedure where and I think my take home on the biomarkers is that it's mainly good for the cardiac patients than anywhere else that I could use it. And also in the setting of sometime in the nephrotoxic or ninja study, which showed that it is effective. So it's just when you see the patient, that's more important.
Dr. Raina, when do you think is a reasonable time frame where this LDL apheresis will be routinely available for clinical practice?
Welcome to my world. So we have now in the US getting more available for last 3 years. I've been in touch with All Indian Institute of Medical Sciences. We have some challenges there, and with hopefully it will move along, but within 2 to 3 years, there was a lot of noise about it, and it's actually getting available in US. So give me another 3 to 4 years. I need to have some data. I need to have some interim long-term data about the treatment and more convincing. I'm not worried about the transitional model here. It's been proven very well in the basic science or in the other studies, but I think we need more long-term data. And now we have approval for adults, so it will go more widely as compared to peds because we have more patients. So give me another 3 to 4 years.
Kalyavani, can you take the other questions?
You're on mute, Kalyavani. Dr. Kalyavani, you're on mute. Is it just I cannot hear or you guys cannot hear?
No, even we can't hear.
Dr. Edwin, can you hear? Because I cannot hear Dr. Kalyavani.
No, I can't hear her also. I can't hear.
Sidharth, I have a question for you.
Yes, Dr. Raina.
I'm looking into your update in the AKI and neonatal. First of all, congratulations, excellent work on the neonatal AKI. How much do you think the people are getting involved with the concept of neonatal AKI in India or in developing country? Because in the US, it took us a lot of time to convince neonatologists.
Yeah, I know. In fact, when I joined pediatric nephrology practice, we had no liaison with, say, the pediatric cardiac intensivist or even the neonatologist. But in the last 10 years, I'm sure that with our better collaborative efforts with them, the awareness about this is increasing, and we see even neonatologists talking about the AKI and the KDIGO classification. So I think it's increasing now. It's much better because of better collaborative efforts with them.
Yeah, you have to bring them into that effort, and I think they're more. Dr. Kalyavani, can I hear you so I can answer your question? I cannot hear you. I still cannot hear you. You can text it to us or to Dr. Edwin. He can answer.
We can't hear her. Dr. Raina, do you think that for these FSGS patients before transplant, we need to routinely do this LDL apheresis or probably watch the proteinuria and then do it post-transplant, which would be a better strategy?
Yeah, very good question, because that's what we have been debating of the transplant. I usually do not prefer to do it before, because it's not going to help me much if I do it before, because we don't know. But the patients who are high risk, like the patients who are Caucasian, they have an FSGS for a long time, resistant, genetic testing negative. We even don't do prophylactic after until as they reoccur. So our protocol here is if you reoccur, then you do the treatment and give 1 gram of salmeterol. So yes, there are studies which have done it perioperative and then do it post-operative. I don't think it's gonna be approved in the US at this point of time because it's a drug device and you need to have a documented diagnosis. And doing after the transplant, you get so much of immunosuppression and you get all those priming with hemoglobin. You don't want to remove those and potentiate the transplant rejection.
Dr. Raina, if I can ask you a question on FSGS post-transplantation. Can you hear me, Dr. Raina?
Very well.
Yeah, we can hear you.
So we very commonly see consults for preemptively doing a transplant in FSGS children. So would you do a preemptive transplant in a child with FSGS, or you would like him to go on dialysis, lose his renal function for a while, and
you know that
albumin for a while, and then transplant him? So this is a very common question which is in our mind very commonly.
You know that we are stuck with this part of the guidelines for almost 4 months, and we were fighting to what the evidence is. So a couple of things I will definitely say with the patients who have a high risk for the transplant of FSGS. I'm not saying that you should, but I would use a disease donor and save it further live-related donor down the road. I have not done the preemptive. It's not going to happen with us for the preemptive unless they are renal failure or they have FSGS, which is non-responsive to any kind of immunosuppression, nephrotic syndrome, they have cardiovascular involvement. Doing a preemptive, I have to drag a feet with the FSGS, especially if they are negative for genetic testing, because the reoccurrence rate is pretty high. So not in the US, but again, every world has a different etiology and aspect. And these patients are pretty tough when they go for a transplant board, because we want to save their life. We want to give them a kidney. We also want to do something that it doesn't reoccur. And you have to wait for our guideline, not mine, but our guidelines together.
Thank you.
Dr. Kalyavani, can you hear me?
Question is, why do we not see a response with lipid lowering agents? Any role of combination agents?
So you're talking about using the HMG coenzyme inhibitors, right?
Yeah. Yes, sir.
We do give it to them. The response for that is, it is not the fraction that's really, and I spend a whole 20 minutes on the slide about the role of lipoprotein lipase and LDL. With HMG coenzyme inhibitors, you're just affecting certain part of the LDL fragment and the LDL. You're not inhibiting the other cascade of cholesterol. And mainly you see the triglycerides levels are pretty high in these patients. So you are hitting only one target with the HMG coenzyme A, but you still treat them in order to prevent the vascular involvement. Plus, it is not related, the dose is not related to the cumulative response on the peripheral levels. This is, you can see a very quick response with the removal of the lipoprotein. So it's a quantification of removal and multifaceted factors contributing to the lipoprotein. And third is with HMG coenzyme, you're just on one fragment and nobody knows what's the outcome of that.
Okay. And Edwin, sir, you want to take the third part of the question?
Go ahead, yeah.
What about the role of total plasma exchange in children with high dose dependent nephrotic syndrome with steroid side effects? Have you tried this, and your comments?
No. Answer is no. Plasmapheresis is a total different mechanism. My answer to that is no. And people get confused with that. You can do it, but there is no role. Even after the post-transplant, we do plasmapheresis in an anticipation. We are removing the SUPAR or other chemokine factors that is potentiating the FSGS. The response rate, the graft failure rate is around 30 to 40%. So TPE has no role as far as my understanding is. If you're doing, you have to reuse the adsorption technique to remove a larger fragment and a removal of all these factors that can contribute. So it's a postulate. You can do that to make yourself happy, but I don't think there is any response. I don't see any data of the response. But right now, the centers who do not have lipoprotein apheresis, they still use plasmapheresis post-transplant. The data is mainly on post-transplant. I have not done it for the steroid-resistant nephrotic syndrome for plasmapheresis because I know it will not be approved in my center.
Okay. Is there any role of total plasma exchange in case of vasculitis and severe form of HSP nephritis, which is not routinely responding to immunosuppression?
I've never seen any cases of not responding most of the time. This is very postulate and hypothetical question, so answer to that is no.
Okay, fine.
It's certainly an IgA, and I have hardly seen any crescentic IgA with HSP. They respond well, and they do very well with cytoxan. Worse to us, you go with rituximab. If you're going to that route, it is all postulate. There's no role. If the person asking question has some data, good for it, but there is no role.
No. Okay, there is already one question which has been answered by Dr. Sidharth. The question is, for the calculation of fluid overload, do we include insensible water losses? So that's it. Can you take this question?
Yeah, it's not used in the definition. It's not used. We don't look at the insensible losses in these patients.
Okay, fine, sir. Edwin, sir, do you have any questions, sir?
No, nothing. It's exciting to hear about the role of LDL apheresis. We've been reading about it for long, but it was really nice to hear it from the horse's mouth about the excellent work being done, and probably we look at a better outcome for these patients with FSGS who have very poor outcomes. It's like beginning a transplant, knowing very well it's going to recur. That's sort of a negative feeling. We start working up these patients. That's and true. Now we know that there's some light at the end of the tunnel, and probably we should be able to do all this.
Okay. Then we'll close the session, sir. We are done with the questions. The final comments, sir. Edwin, sir, you can give the final comment and we'll close the session, sir.
Yeah, Kalivani, I must thank you and Dr. Mehta's hospital and their team for putting together this very nice program and having two eminent speakers today, Dr. Sidharth Sethi, who's well known to all of us and who's a rising star, I should say, already a risen star in the field of pediatric nephrology. And of course, Dr. Rupeesh, Raina, first time I've listened to you. Excellent work from your side. These two areas are something that are of great concern, especially the follow-up of AKI, even in adults, has been quite bad. And we know that about 25 to 40% of patients do land up with CKD. There's a large group of patients who come in with CKD of undetermined etiology, some of whom would have had some subtle AKIs earlier in life, and that's not been really noticed or followed up. I personally have seen a lot of patients who have come with diarrhea-associated acute kidney injury and then landed up with CKD 15 years later with absolutely no symptoms but a creatinine of 10 milligrams. FSGS continues to intrigue us, though there was a lot of talk about SUPAR earlier, and we also did some work on SUPAR, and then we knew that SUPAR could be present in many other glomerular diseases also, though there was a lot of hype about SUPAR as it came in initially. But then as a biomarker, it really lost its value because it was found in many other glomerular diseases. However, the treatment of FSGS is always very disappointing, and this lipid apheresis and all that, LDL apheresis would go a long way in providing some hope for these children and young adults with FSGS. I have nothing else to say, Kalaivani. Thank you very much for the opportunity. Thanks to you, both gentlemen, for sparing your time and sharing your knowledge for the benefit of young, budding pediatric nephrologists in this country. Thank you very much. Good night.
Thanks, Dr. Edwin. Thank you, Sidharth, and thank you, Dr. Kalaivani, for everything. Thanks a lot. Bye-bye.
Thank you.
Thank you, sir. Sorry for the technical issues, sir. Thank you so much.
Thank you.
Thank you, sir. Good night.
Thank you. Good day.